Hi, I'm Agnieszka Jaworska from University of California at Riverside, and today we're talking with James Blair, Chief of Section on Affective Neuroscience at the National Institutes of Mental Health. Our topic is psychopathy, so we'll start by understanding a little bit of what psychopathy is and how it's different from other related phenomena, and perhaps different from how lay people understand psychopathy.
So psychopathy is generally regarded as an emotional disorder that puts the individual at risk of increased levels of antisocial behaviour. The emotional component really is this, striking reduced empathy, striking reduced guilt, striking reduced attachment to significant others, and this set of emotional features is the thing that makes the individual of psychopathy stand out, amongst other individuals who engage in antisocial behaviour.
Could you say a bit about the difference between psychopathy and sociopathy?
So, sociopathy was the term used several iterations of DSM, the Diagnostic Statistical Manual that psychiatrists use to diagnose psychiatric conditions. It was a term used, I think, in DSM-3, and it was to identify what was thought to be an individual who was at risk for high levels of antisocial behaviour because of some form of social cause. Over time, the data has more strongly indicated biological underpinnings to some aspects of some individuals, particularly these individuals with psychopathy, who engage in high levels of antisocial behaviour. Within DSM, that has been represented as what's called antisocial personality disorder for adults and conduct disorder in children. In DSM-4, those criteria were pretty well completely based around behaviour, whether relatively large amounts of antisocial behaviour is being committed. In the DSM-5, which has just been released, the terms of psychopathy and antisocial personality disorder or conduct disorder in childhood are beginning to get integrated. So we have this what's called a specifier for example, in conduct disorder, it's called the lack of prosocial emotions specifier, which corresponds to the emotional component of psychopathy. So we see again references to reduced attachment to significant others, reduced levels of guilt and empathy, and even caring about schoolwork.
Could you explain, in terms of the research you have done and other research, how you understand currently the underpinnings of psychopathy?
So we assume there's two major problems that these individuals face. The first of these relates to problems in empathy, particularly difficulties with processing the distress cues, the sad, the fearfulness, the pain of other individuals, and possibly also happiness, but certainly the sadness, the pain and the fear of other individuals. So they respond to these emotional indicators in a much more muted way than a healthy individual does. And this is deeply problematic because it's one of these, these are social reinforcers that we find aversive, and that actions and objects associated with these emotional expressions in other individuals we learn to judge as bad. We value them as bad or aversive and something to avoid doing. We don't want to harm other individuals because the consequences, the distress of the other individuals is aversive. So that's the first of the problems, and then the second of the problems are based around deficits in what can be termed reinforcement-based decision-making. So decisions based around reinforcements, in the sense of decisions based around rewards and punishments. And we see specific problems in specific forms of computation that allow you to do successful reinforcement-based decision-making in this population. I mean, they don't respond very successfully to reward information and punishment information, and they don't represent the value of objects and actions in the way that a healthy individual does. And that relates to problems at the neural level, certainly in the amygdala, caudate, and ventral medial prefrontal cortex. The amygdala is really important for learning about, for doing what's called stimulus reinforcement learning, for learning that some things are good and some things are bad. And one of the ways, again, that we learn about the goodness and badness of things is looking at other people's emotional expressions, particularly distress cues and happy faces. And so we see problems in the amygdala and responding to fearful faces and sad expressions in other individuals, and using that information to learn about things that harm other individuals. And then the caudate and ventral medial prefrontal cortex are particularly important in aspects of response outcome decision making. So the caudate allows us basically to detect when we've got surprising rewards or surprising punishments. And the critical thing about getting surprising rewards and surprising punishments is that they're cues for learning. If we suddenly get an unexpected reward, we want to do whatever got us that unexpected reward again as fast as we possibly can, because we might get the reward all over again. And the caudate is very important for spotting that unexpected reward, being sensitive to the level of unexpectedness of that reward, and then implementing the actual learning that this type of response is associated with this type of outcome. Ventral medial prefrontal cortex allows us to represent the expected level of outcome information, and of course it's the expected level of outcome that actually governs our decisions. If we know that two actions will get us reward, one of which will get us $100 and one of which will get us $10, obviously we want to be able to pick successfully the action that's going to get us $100 rather than the action that's going to get us $10. And the idea is those processes in detecting the surprising level of the reward or the punishment, and in representing the expected value of the object or action, the amount of reward or punishment that you're expecting to get if you do this particular action, are deeply problematic in this population.
Do you understand the reinforcement decision making as a single system, or is it multiple systems possibly in conflict with one another?
So there are certainly multiple different types of learning that are crucial for allowing you to do decision making. So one of the types of learning that you have to do is what's called stimulus reinforcement learning. Learning that some stimuli, some objects are good and some are bad. Some have positive valence and some have negative valence. Now, the amygdala is absolutely critical for allowing you to do stimulus reinforcement learning. Then you've got a process that is called response outcome learning, learning that a particular response is going to get me a reward, or a particular response is going to get me a punishment, so I should do that response rather than the other response. And then you've also got what's called habit learning, which is more sort of stimulus response, that whenever I see the stimulus, I generate that response. It's not clear to what extent the stimulus reinforcement learning process and the response outcome process actually conflict with each other. Simply because the types of decision making or the types of learning problem that one is designed to deal with are not the same as the problems that the other one is designed to deal with. There are data to suggest that habit, what you've learned as a habit, can interfere, or response outcome decision making can interfere with your implementation of habitual learning, or habitual learning can take over from response outcome decision making. It's not my work, I don't know it very well, but I know that there are data on that type of interference process. My assumption with respect to psychopathic traits, as I've said, is there's problems in stimulus reinforcement learning, there's problems in response outcome learning. I think that it's potential that habit learning may be intact, but we haven't really documented it very well.
I'm interested in the relationship between the decision-making paradigm that you have been talking about and the idea of perception of salience of the features that appear important to the individual. How are these two related?
Salience is used as a term in many different contexts. Where there's an argument that the amygdala is a salience detector because it responds to salient emotional features and some other highly notable stimulus features. To me, the term salience, I don't think it gives us much clue as to regards the computations that are going wrong. For me, what I think the problem with the amygdala is in stimulus reinforcement learning, and of course what's salient is effectively the types of things that have been associated with reinforcement. So, if I've been shocked for touching the blue triangle, when I see a blue triangle, that's a highly salient stimuli because indeed the blue triangle is represented in temporal cortex, it's activating the amygdala. The amygdala is then boosting the representation of that blue triangle, so I look towards it and stay away from it. Other people refer to the workings of these structures called the dorsomedial prefrontal cortex and anterior insula as a sort of salience network, because again they are seen when you get salient information such as error information. Again, I don't think the use of that term is terribly informative, because what we really want to know is what these regions are doing. And what they seem to be doing, we have, there's some relatively detailed modelling work on what dorsomedial prefrontal cortex is doing, representing response outcome types of associations, response outcome information, and then in situations of conflict or in situations of error information, basically redirecting motor responding through anterior insula, inferior frontal cortex, and then on into caudate. So the difficulty I always find with salience as a term is it doesn't provide very much explanatory power, that we need to understand how brain areas achieve particular types of functional process, and just saying that something is salient I don't find as a terribly informative thing to say.
Is psychopathy something you're born with, or can there be acquired psychopathy?
So that's not an easy question to answer. We know that there's a strong genetic component to psychopathy, so that we see the heritability ratings of around 0.7 for the emotional component, which is high, which is shows us a very strong genetic contribution. But the fact is that because it's 0.7, it's not 100%. It means that there are environmental factors that are determining the level of somebody's psychopathic traits. What those are have not been well worked through. We don't really know what environmental factors might be contributing to that, whether they're actually having an impact on the pathophysiology, whether they're only having an impact on how the pathophysiology expresses. I mean, it's likely to be both, but we just don't have the data. There is a reference to something that's called acquired psychopathy, which is usually associated with lesions to orbital frontal cortex, but we're seeing something very different from a patient who's had a lesion of orbital frontal cortex from an individual who has developmental levels of high psychopathic traits. So the classic findings we get with orbital frontal cortex damage is to do with irritability and reactive aggression, if there is any increase in aggression at all. And not in many cases there isn't, but if there is, it's that irritability, emotionally labile, selection of actions being inappropriate. That is there in individuals with psychopathy, but it's only part of the picture, because again, when I was talking about the areas involved, we're talking about the caudate and the amygdala being at least as important as ventromedial prefrontal cortex in understanding the problems that we're seeing in individuals with psychopathy, and obviously a case of acquired sociopathy following a frontal lobe lesion. We're only talking about the ventromedial prefrontal cortex, so it's only part of the actual pathophysiology, and of course we're talking about something that's not, that was acquired, not developmental, and so the implications of the basic problems for the development of the rest of the brain are very, very different from, if you have it from a very early age to suddenly get an acquisition of a particular problem in adulthood.
Could you elaborate on that aspect, the difference between developmental versus acquired, like if there could be a lesion to the exact parts that you think are affected in psychopathy?
Oh, so if there was a lesion that occurred in amygdala, caudate, and ventromedial prefrontal cortex, or at least a level of damage, it's likely that if there was a lesion, again, it's very important to remember when we're talking about this psychiatric condition, we're not talking about holes in the head, we're not talking about amygdala that's gone, caudate that's gone, we're talking about amygdala that's not working as well as a healthy individual's does, a caudate that's not working as well as a healthy individual's, ventromedial that's not working as well as a healthy individual's. But if we could disrupt the functioning of those areas in an individual, if we wanted to do such a undesirable experiment,
or if it happened,
my expectation would be yes, we would see something that was very close to developmental, classic developmental psychopathy.
So in our project, we're particularly interested in love, and psychopathic individuals are thought of to be paradigmatic examples of persons who don't love. So could you speak to that aspect of psychopathy a little more?
Yeah, I mean, the data very strongly indicates that this population does have significant problems with attachment to other individuals. So they don't maintain contact with siblings, they don't maintain contact with parents, they don't maintain contact even with their own children, and they don't maintain contact with romantic partners. I mean, one of the features that is used to index psychopathic traits in adults, at least, is the frequency with which the individual engages in new romantic entanglements. So, they don't stay maintained with one individual.
So in terms of the biological and neuroscientific understanding, how would you explain that aspect of psychopathy?
So again, it's not an easy answer. Partly because we don't really understand the mechanisms of attachment. One of the things people talk in terms of is the critical role of striatum in allowing us to find another individual of reinforcing value. If that's true, that's what part of the component what attachment is, then that corresponds very nicely with some of the problems we see in this patient population, where indeed we do see reduced signalling in reinforcement generally within striatum, within caudate. So that would be, if we're having that problem for reinforcements generally, it's not surprising that we would see them for the specific social reinforcement of the person that we would otherwise be attaching to. The amygdala may also play an important role in the generation of attachments. I mean, it's certainly been argued. Again, it's not clear that a model of attachment, the attachment process, is really lacking. A computational model of the attachment process, at least as far as I can see, is lacking. But again, the amygdala has been implicated. The types of stimulus reinforcement learning, the learning that some things are good and some things are bad. I mean, part of the whole process of attachment is learning that the person I'm attached to is a good thing. So I wouldn't be surprised that the amygdala is involved. And again, we know that process of learning that things are good or learning that things are bad is disrupted in this population. So I'm assuming that the impairments in the formation of attachment fall out of these types of fundamental emotional learning system deficits. And then also maybe one of the ideas is the ventral medial prefrontal cortex allows you to represent effectively your emotional information to yourself, how much happiness or sadness, how much good value versus bad value you're actually experiencing at the time. And of course, part of the big thing of attachment is indeed seeing the loved other and generating that experience of the positive valence of the presence, and actually being able to represent that, feeling that. So if they're having problems, as we do see there is these problems in representing value information, expected value information in ventral medial prefrontal cortex, then indeed they just wouldn't be experiencing, or irrespective of the emotional learning problems, they wouldn't be even experiencing the emotion in the way that a healthy individual would be. So my guess is that those problems do indeed underpin the reduced attachment, reduced love that we see in this population, and it's possible that there are additional impairments that are yet to be identified.
So you think of the problems with attachment in psychopaths as a consequence of the general decision-making problems? Of
the general problems in emotional learning, and potentially the general problems in the representation of value information, yes. But I acknowledge the fact is that it could turn out that there will be a good model of attachment, and that will identify there are additional functional processes that are going on than just those that I've characterized. And those might also be impaired in this population. But in the absence of that information, I can't speculate.
Could you talk a little bit about the emotional profile of the psychopath, sort of the loving attachment emotions they don't have, but what kind of emotions would one expect from them? And is there anything else that they would be lacking, like say in terms of anger and fear?
So fear, definitely. There's definitely reduced fear and anxiety in this population. Looks like there's reduced sadness. Again, fear and anxiety, sadness appear to rely on the functional integrity of the amygdala and potentially, at least with sadness, ventral medial prefrontal cortex. But then there are other emotions like anger and disgust, and there's no real reasons to believe that either of those are disrupted in this population, or at least certainly the generation of anger responses. There was a recent study that I was involved in, which was looking at people's knowledge of their emotional events, and you see marked impairment in their understanding, in their knowledge of their own bodily response to fear scenarios, but their understanding of their body's response to angry and disgust scenarios was the same as a healthy individual.
What about the goal profile of a psychopath? Do they have goals in the normal sense? Do they have different types of goals? Or how would you characterize that?
So I don't think there's any direct data looking at the representation of goals within individuals with psychopathic traits. We can certainly assume on the basis of their reduced reward processing that any representation of goals is going to be weaker, because part of the whole point of getting a goal is to get a type of reward, and if they're not representing the reward as strongly, then the idea would be the representation of goals will be weaker. But the actual generation of goals, there's no reason to believe. I mean, certainly when you do experimental tasks with individuals with psychopathic traits, there are some individuals that are completely unmotivated to participate, but many individuals are relatively, interested in, or are prepared to participate in these relatively short studies, and will get frustrated if they perform poorly, particularly if there's an incentive to perform well. But it's not actually been systematically documented lifetime goals and whether there are any differences between lifetime goals of an individual with psychopathic traits and a healthy individual.
Is the research that you have done or other people studying psychopathy pointing to a possible treatment for psychopathy?
So currently the situation is that there's a considerable body of data showing that this population is significantly more difficult to treat than other individuals that are showing elevated levels of antisocial behaviour. One of the things that's very important to remember is that if you go to the population of individuals showing elevated antisocial behaviour, we've got some individuals who show these elevated levels of psychopathic traits. That looks like there's at least a secondary problem associated with actually a very different type of pathology, where you get this highly increased emotional response, a really heightened threat response, and sort of rage responses, reactive aggressive responses to threat or frustration and provocation. And then you've got obviously a lot of individuals that are, to all intents and purposes, healthy, but due to their social and environmental circumstances have engaged in antisocial behaviour to make ends meet, or something's gone wrong one day and they've ended up in a forensic setting. As regards treatment studies, it's relatively well documented that individuals with psychopathic traits are particularly difficult to treat. Not necessarily completely impossible to treat, but certainly significantly more difficult to treat. One of the things that, why I do the work that I do is because my goal is, by identifying the pathophysiology that these individuals face, it's possible to identify treatments that should be particularly effective at addressing that pathophysiology. As we understand, whether it's psychosocial or psychopharmacological, the effects of those types of interventions on the brain, we can actually look for the sorts of interventions that might have a chance at addressing the pathophysiology that we see in this population. And the other thing that I find useful is that we can use the types of tasks that we develop as effectively as what's called biomarker tasks. So they mark out the pathophysiology, and we can examine whether the treatment actually is addressing the pathophysiology. And we can do it in a relatively efficient manner that doesn't require sort of long-term follow-up of recidivism and things like that. We can actually see whether the pathophysiology is being addressed.
Can you explain a little bit more this idea of a biomarker?
All the biomarker is supposed to be is it could be a neuropsychological test, a computer test, or it could be an fMRI task that identifies the problem that's faced by a clinical population. So in the case of what we use with individuals with psychopathic traits, what my group uses as the two sort of prototypical biomarkers is the reduced amygdala response to fearful expressions and these problems in the caudate and ventral medial prefrontal cortex with respect to picking up unexpected reinforcements and representing expected values. So those are the biomarker tasks that we use, and that we're attempting to see whether different interventions actually address those underlying problems.
So how would you explain the usefulness of knowing that a particular area of the brain is disrupted?
So again, I mean, the really major gain of the fMRI work, partly it is that you identify problems in specific brain areas, because that's useful because we can then look to see whether we can find interventions that will be particularly targeted for those brain areas, or at least have an influence on those brain areas. If we know that an intervention has no influence on the brain areas that we know are disrupted in this population, then obviously that's not, it's not going to be our first port of call as regards as a potential novel intervention to try. The other thing to remember that fMRI now is not only about just saying that region X doesn't respond as well to a particular type of cue. I mean, especially when you're thinking in terms of the decision-making literature, what you're really modelling is the computational processes. So, I've talked about the surprise level of the reward. It's called in the sort of jargon term a prediction error. So you're identifying the difference between what you expected reward-wise and what you received reward-wise, or what you expected punishment-wise and what you received punishment-wise. And so not only does the fMRI allow us to identify which brain areas are potentially problematic, but exactly what type of computational process they're not performing in the patient population, which gives us a big step. I can identify with neuropsychological studies that there is a decision-making deficit in this patient population. I cannot show that decision-making deficit relates to a problem in expected value representation, or a problem in prediction error signaling, or a problem in both, unless I do the fMRI work. So it gives me a computational sophistication that I would lack if I was only doing behavioral work. And also, I think a good model has indeed got to really imagine how different regions are integrated in their functioning in order to achieve the particular task. I mean, we know, for example, at the relatively simple level, emotional attention, so attending to a salient emotional feature. We represent an object in temporal cortex. If that object is associated with an emotional response from previous learning history, it will activate the amygdala. By activating the amygdala, because the amygdala is reciprocally connected with temporal cortex, it will boost the representation of that object in temporal cortex. And since we know that attention is all about which objects win the process of competition, do I represent that object or do I represent that object? And the representations are crudely fighting with one another, attempting to inhibit each other. By boosting one, the emotional one, it means I'm going to attend to it. That's the one that's going to win the competition for representation. And so, by allowing us to identify the network of systems and how that network achieves particular jobs that the brain faces, we can get a much richer, much more sophisticated model of the problems of our particular patient group.
You have been talking about psychopathy as a disorder of empathy, and there are other disorders such as autism that are also understood as disorders of empathy. So how would you explain the similarity and differences between these two?
So it's very important to remember that the problem with a term like empathy is it's used very differently by very different people. And so one of the things that I did was to try and start specifying what types of functional process might correspond to empathy. And we can basically make a distinction between what's called cognitive empathy or theory of mind, which is representing what somebody believes or intends or their knowledge base, versus sort of emotional empathy, which is generating an emotional response to somebody's face, to the sound of somebody in pain or happiness, even body posture, and even text. So when we read a novel, we may generate a empathic emotional response to the plight of the protagonist, and those two processes are very distinct at a neural level and at a computational level. One's emotional, one's more this sort of representation of these mental states. And what's particularly interesting is that we see that individuals with autism have these very marked problems in the representation of mental states and the representing other people's knowledge and their beliefs and their intentions, but have much less of a problem with the emotional responsiveness. They have some problems generally with face processing, but not really problems that are specific to emotional information, and certainly not distress cue information, the sadness, the fear and the pain of other individuals. In marked contrast, individuals with psychopathy or psychopathic traits have absolutely no problems in representing the mental states of other individuals, their knowledge, their beliefs, their intentions, but they show very significant impairment in this, emotional empathy. They show, reduced autonomic responses to the sadness, the fear of other individuals, the pain of other individuals, reduced amygdala responses to those cues. They show reduced recognition of body postures of fear. They show reduced recognition of the sound of another individual in distress, in fear or sadness. So, and these aren't problems that we see in individuals with autism. So it's part of the problem really of using a term that really can be used for two very, very different functional processes. One functional process we see is disrupted in autism, cognitive empathy. One functional process we see is disrupted in individuals with psychopathic traits, emotional empathy. And in fact, actually in psychopathic traits, is a very specific form of emotional empathy based around distress cues and potentially the happiness of other individuals as well.
What do you see as some of the unresolved issues in the research in psychopathy, the direction in which your research is going, for example?
So the two biggest problems that we really need to solve are, obviously we need effective treatment. And so, we need to be able to help these individuals, allow them to experience the full range of emotional repertoire that we'd like a healthy individual to experience, and hopefully we'll all then benefit from the decrease in these emotional problems in this population. And really so having the development and identification of good treatments that really, really help this population. And partly related to that is that we have a really, I think, relatively well-defined understanding of the computational impairments, the information processing impairments that we see in individuals with psychopathic traits. We have a pretty good picture about the neural systems that are disrupted in individuals with psychopathic traits. But what we really don't know anything about at all is the molecular level, the neurochemistry of psychopathic traits. And obviously that potentially directly relates on to treatment, because if there is a pathology of neurochemistry in this population, which there almost certainly is, then that may help us, guide us towards interventions that would play a role in attempting to address this pathology at the molecular level.
Is it helpful in research on psychopathy to compare the findings on other problems with decision making, let's say like addiction or frontotemporal dementia or something like that?
So one of the big moves at the moment at NIMH is the idea of this RDoc program, this research document program, and it's based around identifying neural systems that, rather than saying, this disorder is the disorder of this neural system, we're saying these are neural systems that can be dysfunctional, and when they're dysfunctional, we may see this type of behavioural problem, and we might see it in several different disorders. And so we've got this problem in individuals with psychopathy or psychopathic traits of reduced responsiveness to reinforcement cues, reduced representation of expected values. some of that does seem to be present in other what's termed externalizing disorders. And externalizing disorders are indeed some individuals with drug addiction and also some individuals with attention deficit hyperactivity disorder. And so the goal of this sort of adult program is maybe to get away from talking about disorders and talk about, types of pathophysiology that have this set of behavioural consequences that they may be more likely in people who are currently classified as having attention deficit hyperactivity disorder or conduct disorder or drug addiction, but it may actually mean that we'll be really addressing the pathophysiology that's in patient A with this diagnosis, patient B with that diagnosis, and patient C with another diagnosis at all. So in other words, I think it's extremely important to compare and contrast across disorders, because it allows us indeed to see whether these systems break down in a similar way in other individuals. So in individuals with ADHD who show decision-making impairments, are they showing all of the same decision-making problems that an individual with psychopathic traits is showing, or is it a very much more selective problem? Is it only, say, in the role of the striatum in detecting unexpected rewards, and in fact they're totally intact in the representation of expected value information in ventral medial prefrontal cortex? If that's the case, and there are data suggesting that might be the case, then the behavioural implications of the decision-making deficit will be rather different.
So I'm wondering whether interdisciplinary research or collaboration of the type that we're trying to do here at this retreat, is that of help to you in any way?
That's a tricky question. It all depends. I mean, certainly interdisciplinary research, my direct collaborations are with people who are doing basic neuroscience relating to animal populations, people who are doing genetics research, people who are trained up as MDs, people who are trained up in pharmacology. So without a doubt, on a day-to-day basis, my research program is indeed multidisciplinary. There have certainly been direct examples of the impact of philosophical discourse on my work. The most dramatic for me personally was by Sean Nichols some years ago, where my original model of the development of morality was based purely around emotional reactions, and he pointed out quite rightly that would only get us a sense of badness and wouldn't get us a sense of immorality, and that you had to have something on top of that. And so that for me is certainly the most dramatic. It showed that my early position was just completely insufficient, and that I needed to expand it to have a fuller account of the development of care-based morality. So when these things happen, as they do in interdisciplinary meetings generally, then yes, they are a benefit, without a doubt.
And how about in the other direction, having participated in discussions of our philosophical papers? Do you think that your perspective and the neuroscience perspective can help, say, philosophers in our research? So
when I hear philosophers talking about wanting to make empirical predictions, then I think it's critical that the philosopher needs to know the empirical literature, because many of the empirical predictions they're making have been addressed. Or alternatively, if the philosophical model is a model of what humans do, I think it's critical to read the literature on what humans do in order to see whether the model can survive in the face of the empirical literature. But that's not the only goal that philosophers have in the work that they do. And obviously when it's less to do with what people do and maybe looking at, say, the structure of a particular concept, that may be relatively divorced from the type of data and information that I can provide. So again, but I think there's clearly, from the meeting that we've had here, clearly a lot of philosophers who are interested in making empirical predictions and think it's, at least part of the role is to generate a model of what humans do. And so I would like to believe that the information is useful. You can never predict what happens, but I would think it was uncunning not to incorporate the empirical data if you've got a position on what humans do.
Thank you so much, Dr. Blair.
You're very welcome. That was good fun.